This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program. We'll go through some upcoming events, introduce our speaker this evening, Dr. Alan Pocinki, and then have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who is also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008. The same year my wife Carol passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 100 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the recordings will be posted on our website at edsawareness.com for later repairing. You can receive email announcements for future sessions by requesting the free report, the guide, on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store currently is the only funding for the program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. We're actually excited that we have another sponsor who's helped us with this particular webinar. There was a program on August 6th that was in King Ferry, New York, and it was a walk and a run. And Elizabeth Shaw organized that. There were 62 attendees, and they had fundraising, and they are currently helping us and supporting some of the webinars that we're conducting. So we're very excited about that. So just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in the program. The information is not advice. If you're having medical problems, please call 911 or the emergency services in your location. Always consult a doctor before making any changes to your treatment.
Mark your calendars for our next webinar on September 6th. Dan Doherty from Genelux Corporation is going to talk about pharmacogenetic testing and to assess altered drug metabolism. And to view our upcoming speakers, see the webinars page at edsawareness.com for the full schedule. For those attending live tonight, there will be an opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon at the top of your screen. After typing in your question, click the orange button to submit. Our speaker for tonight is Dr. Alan Pocinki. He's going to speak about psychiatric misdiagnoses in EDS and when is anxiety not anxiety. Dr. Pocinki has been active in the EDS community for many years and recently served on an international panel of experts to develop consensus statements on the evaluation and management of autonomic dysfunction and fatigue in EDS. He's also authored a chapter on sleep disorders in the Dysautonomia Project, which was published last fall. Dr. Pocinki is a clinical associate professor at Washington University Medical Center and a fellow of the American College of Physicians. He received his MD from Cornell and completed his internship and residency at the Washington Hospital Center. His patients have voted him one of the top primary care doctors in Washington in a leading consumer magazine, and his peers have similarly voted him one of Washingtonian magazine's top doctors. So it's my pleasure to introduce Dr. Pocinki. He's just been so giving of his time and his expertise for many years in the EDS community, and I'm honored to have him speak with us tonight. Dr. Pocinki, you're going to see your slides are going to load here, and I'm going to go ahead and turn over the microphone to you. Thank you for joining us.
Thank you, Deanne. Thanks for that nice and elaborate introduction. And thanks to you and John for all the work you do putting together all these webinars. For those of you who haven't looked at the archive of past webinars, it's really an invaluable resource on almost any Ehlers-Danlos-related topic you might be interested in learning more about. So, and I guess I'll also put in a plug for our next speaker and the next topic of pharmacogenetics. I've been working with the Genelex people for several years, and pharmacogenetic information is often invaluable in figuring out why people have had problems with medications in the past and predicting what they might do well or do poorly with in future prescriptions. So I'd suggest you put that one on your calendar. A couple quick disclaimers. Medications, I will mention some off-label uses of medications, and I have no relevant financial conflicts of interest to disclose. So our topic tonight is how symptoms of autonomic dysfunction can be easily misinterpreted or misdiagnosed as symptoms of psychiatric illness. And this is something I pondered putting together a talk about for a while, and finally put together the first version of this talk a few years ago after seeing a young woman with initials KM. At the time I saw her, she was 21 and had first been diagnosed with panic and anxiety at age 5, because at that time, even small things would frighten and upset her. And her family figured out that the fewer things they exposed her to, the fewer episodes of her being upset they would have to deal with. So she was homeschooled. Any attempt to go to school would have just been overstimulating, and she would have been upset and actually physically ill. So unfortunately, this became sort of self-perpetuating, and she became agoraphobic, never leaving the house, because anytime she did leave the house, her heart would start pounding, and she would get nauseous and break out in a cold sweat and have to return home as quickly as possible. So she was treated with a great variety of medications, many kinds of counseling, psychotherapy, to try and help her deal with her anxiety, but really with only modest improvement. Turning point came at age 17 when the rest of her family was going to a baseball game here in D.C., and that required taking the Metro. So they had little hope of her actually going to the game with them, but they thought if she could at least leave the house and go to the Metro station with them, that would be a milestone, maybe even get on the train, ride a stop or two. That would be a major achievement for her. So they mentioned this to one of her physicians, who had the idea that since these symptoms seem to have a lot in common with stage fright, people who have to give a presentation or have to perform in public or would often get similar symptoms like this. So he had the clever idea to try propranolol, which many people use, for example, for public speaking, and maybe that would help her. So sure enough, she took a small dose of propranolol, went out with her family, got on the subway, went to the baseball game, stayed through the whole game, went home, and told her parents, "This is the best I've felt in a very long time." So when I met her, she was 21, in college, had lots of friends in college, was on the golf team, and was really enjoying something pretty close to the life of a normal 21-year-old. And yes, of course, she was hypermobile, and over time she'd done a remarkable job of stabilizing her lax joints, and with improvements in muscle tone and aerobic capacity, her autonomic symptoms had since improved significantly, and by the time I saw her, she was able to stop, over the next couple of years, was able to stop most of her medications. But, and the reason that I felt compelled to put together this talk, she essentially lost most of her childhood because the true nature of her condition was not recognized. So another illustrative case was nicely described in the Sunday Times a few years ago. A psychiatrist described the case of a young man who was referred to him for treatment of ADD. So the psychiatrist sensed that something wasn't quite right and sent this young fellow for a sleep study. And it turned out that the man did not have ADD at all. In fact, he had a sleep disorder. And with treatment of his sleep disorder, his ADD symptoms completely resolved. And Dr. Thakkar, the psychiatrist, found and cited several studies in literature showing high rates of sleep problems, as high as about 40% of sleep problems or sleep disorders or abnormal sleep studies in young people diagnosed with ADD. So he concluded this very educational article by pointing out that clonidine, which was used for probably 60 years now to treat high blood pressure, was recently approved by the FDA to treat ADD, and that clonidine also tends to improve sleep. So of course, I was reading this article thinking, okay, great, he's going to talk about the autonomic nervous system, he's going to talk about adrenaline and people making too much adrenaline, and that's why it's their autonomic nervous system that's the problem, but didn't quite get there. So I felt compelled to write a letter to the Times saying, this is a great article. Thank you for shedding light on the misdiagnoses given to many patients with sleep disorders, and pointing out that I see many chronically tired patients who are misdiagnosed with panic or anxiety disorders. And the common thread in all these conditions, as I wrote in this letter, is essentially too much adrenaline. Of course, that's not actually the case, but for the purposes of this letter and the number of words you're limited to in a letter, I left it at that. And I further explained in this letter that after a poor night's sleep, many people's bodies respond to fatigue by making extra adrenaline to keep them going. And the extra adrenaline then can be hard to shut off at bedtime, so they get another bad night's sleep, wake up tired, run on adrenaline, and get stuck in a terrible, vicious cycle. And these concepts were sort of reinforced by feedback I've gotten from talks on sleep disorders and giving talks on autonomic dysfunction. And parents come up to me afterwards and say things like, once we got my son's sleep straightened out, his ADD disappeared. Or once my daughter started sleeping better, her anxiety went away. So again, Dr. Thakkar concluded his article by saying, if you're not already been convinced, consider the drug clonidine. So why would clonidine be effective for treating high blood pressure and ADD and sleep problems? Because essentially the physiologic effect of clonidine is to suppress adrenaline production. So I concluded my letter by saying, thank you for encouraging your readers to see that some apparently psychiatric disorders are instead disorders of adrenaline and the autonomic nervous system. And I think probably his article and my letter probably reached more people and hopefully more physicians probably than any article in a medical journal would have. So let's talk about the basics of the autonomic nervous system. Basically, the autonomic nervous system regulates all body processes that occur automatically. So that's heart rate, blood pressure, breathing, digestion, everything that goes on in your body without your having to think about it. It's a pretty simple system. It's divided basically into the sympathetic nervous system and the parasympathetic nervous system. The sympathetic, people talk about fight or flight. It's largely sort of adrenaline-based. And I find automotive analogies helpful. So we think about the sympathetic nervous system as the accelerator. In most cases, if you want to speed up, if you want to run, you'll increase your sympathetic nervous system activity. And then counterbalancing that is the parasympathetic nervous system. This is the rest and digest system. so that if you've just eaten, you tend to reduce your sympathetic nervous system activity and increase your parasympathetic activity. Similarly, when you're trying to fall asleep, you take your foot off the gas and put your foot on the brake. So there's a lot of dysfunction in the autonomic nervous system that occurs in joint hypermobility syndromes like Ehlers-Danlos syndrome. And I'll give you a couple of sort of constructs or paradigms to try to understand some of this. So one of the most helpful things my patients find is to think about having your own energy reserve, having your own gas tank, and that basically sleep is the one activity that tends to put energy or put gas into the tank, and then daytime activity, pain, emotional stresses tend to deplete energy reserves. And this is a cartoon version that, again, many people find helpful. Say, okay, well, how do we get the system in balance? How do we replenish our energy reserves? And we'll come back to this later after we talk about some of the details of exactly what's wrong. But the basic concept here in autonomic dysfunction in the hypermobility syndromes is that sleep is not what it should be. Sleep quality is poor, so the supply side of the system doesn't work well, and stresses are high. Pain is a chronic problem. Fatigue, just pushing through fatigue to try and get things done, depletes energy reserves. Dehydration or salt fluid imbalances are a problem. Using your brain to do anything uses energy. Emotional stresses uses energy. Work stuff, school stuff, financial concerns, family issues, all that stuff is depleting reserves. So if you don't have a good night's sleep, your reserve tanks are depleted. The central paradox of autonomic dysfunction in syndromes like Ehlers-Danlos is that the more these reserves get depleted, you would think that as your reserves get depleted, you'd get more tired, you'd get more sluggish. And in fact, while you do feel fatigued, the more depleted you get, the more rundown you get, the more exaggerated your stress response becomes. So paradoxically, essentially, the more rundown you are, the less adrenaline you're able to make, the more your body reacts to it, so that if there's only a tiny bit of energy left, you can still do the fight or flight thing if you need to. Unfortunately, this means that your body, by overreacting to minor stresses, is wasting the energy that you're trying to conserve. The other common feature or sort of hallmark of autonomic dysfunction in the hypermobility syndromes is that this exaggerated stress response often triggers an overcorrection. If you hit the gas too hard, your body says, whoa, that's too much gas, and hits the brake. But often the brake gets hit too hard, and suddenly things are slowed down too much, and that triggers another adrenaline surge or a sympathetic surge, which can trigger another overcorrection. This is what I often refer to as the autonomic roller coaster. So this is what this looks like, and I will try to, this is some in-office autonomic testing equipment made by a company called Anstar, and what we do here is we're able to measure sympathetic and parasympathetic activity with specific maneuvers. So at rest, we measure sympathetic and parasympathetic activity. Resting, sitting quietly, doing nothing for 5 minutes, there should be very little activity in your autonomic nervous system. Then we ask patients to do slow, deep breathing, and those of you who've ever seen, somebody overly upset, a helpful person comes along and says, take some deep breaths, because that tends to stimulate your parasympathetic nervous system, as you see here. And then the patient rests for a minute. Then we ask them to clench and strain as if they're extremely constipated or blowing up a balloon or something like that. And that simulates stress and triggers a sympathetic nervous system response. And then there's a break. And then we finish the test by asking patients to stand. And normally when you stand, your blood pressure drops a little bit, and your body compensates initially by kicking in a little extra adrenaline. Then other things happen. Your blood vessels constrict. Fluid that's been parked and blood that's been parked in other parts of your circulation gets moved into your active circulation. so that extra adrenaline goes away pretty quickly. So the left pain is what we expect to see in a normal, healthy person. And the right pain here is what we very often see in Ehlers-Danlos patients who are having autonomic problems. So what you see is here at the beginning, patient sitting quietly doing nothing, and their body senses that something is a little too slow, and it's the gas. But then almost immediately the body says, whoa, we didn't need that much gas, slams on the brake. Nah, that's too low again, so better hit the gas again. No, that's too much gas, better hit the brake again. Even more importantly is here what happens when you stand. So you stand, your blood pressure drops, you hit the gas too hard, almost instantaneously your body says, no, that's too much gas, slams on the brakes. And this is how a lot of people faint. In this case, this patient quickly recognized, no, that was too much brake, better hit the gas again. No, that's too much gas, better hit the brake. No, that's too much brake, better hit the gas again. So this patient has been standing for 3 minutes, and her body is still struggling trying to get her heart rate and blood pressure stabilized. So the other thing that you see right here in terms of fatigue is look how little energy the healthy person used to maintain blood flow to the brain on standing, whereas this person is wasting, 5, 6 times as much energy trying to do the same task. So even sitting quietly doing nothing, this person who's tired and trying to conserve energy is instead wasting it. So what happens when you're in a stressful situation and your body decides to kick in your sympathetic nervous system? Well, you get an adrenaline surge, your chest gets tight, your heart starts pounding and racing, you feel short of breath, your muscles get tense, you feel jittery or shaky, you want to do the fight or flight thing. You can feel nervous, you can get flushed, hot, sweaty, you can be irritable. You certainly, if there's too much adrenaline running around, will have trouble falling or staying asleep. And since you're trying to do the fight or flight thing, you don't want to have to stop and go to the bathroom. So your parasympathetic nervous system or your digestive tract tends to slow down. If you're under some ongoing stress that isn't so acute but is more prolonged, so the common ones we see are things like pain and fatigue and dehydration, then your body is constantly churning out extra adrenaline to try and either respond to or combat these problems. And eventually, if you're faced with too much sympathetic stress and keep your adrenaline levels too high for too long, you eventually end up depleting your tank and run out of reserve energy. And so if you get to this point that I call sympathetic depletion, remember the fuel tank metaphor, if you've put in too little gas because you're not sleeping well and you're going through all these stresses that are using up adrenaline and using up energy, then you get in this overtired situation where you're, despite being tired and having not much energy left, your body's overreacting to minor things. So you have trouble concentrating, you're easily distracted, you're irritable, you have trouble starting things, you have trouble finishing things. You might tend to avoid things that require sustained concentration because that's tiring and you don't have much energy. You'll do things hurriedly, again, because focus is difficult and your energy levels are low. You can make careless mistakes. You'll have trouble with complex tasks like problem solving or decision making. You may have trouble listening because, again, it takes an effort to listen and focus and concentrate. You may lose or forget things because you haven't concentrated well on where you put them, and you'll be easily tired because you don't have much energy to work with. If this keeps going and the more tired you get, the more you sort of push through it, either using your own adrenaline or taking stimulants or caffeine or things like that, then you can get in a situation where you're essentially living on adrenaline. You wake up exhausted. Your body's making adrenaline to keep you going. You're making adrenaline in response to pain. And that adrenaline can mask pain and fatigue. So this is a very common problem. People don't realize how exhausted they're becoming. They don't realize how much pain they're in because the very fatigue and pain that are stimulating adrenaline, in turn, that adrenaline tends to mask the pain and the fatigue. And when that adrenaline is running around, you tend to feel good. You tend to have energy. You're finally feeling good. You're finally getting something done. You start to feel more optimistic. Maybe I'm getting better. You may not sleep well because it's hard to buzz through the day on adrenaline and shut it off at bedtime. But despite that, if you don't sleep well, you wake up tired and you kick in the adrenaline and you're ready to go. You may talk really fast because you're in a hurry to get things done. Gee, this is the best I've felt in a long time. I'm going to do all kinds of things. So what happens if your body decides it needs to increase your parasympathetic activity suddenly? Most of the time, it's going to do this, as you remember in the roller coaster, because you've hit the gas too hard, then you'll hit the brake too hard. But you could have a stomach bug of some kind, or you could have gallbladder problems, or an ulcer, or something else that causes nausea. Nausea or abdominal pain and diarrhea, all those things are associated with increased parasympathetic activity, and parasympathetic activity also causes chills and cold sweat and causes your heart rate and blood pressure to fall, and in general just makes you feel weak and awful. Again, this is your body's attempt to get you to recognize that you're sick and slow down. If you're pushing too hard for too long and you're in this overtired running on adrenaline thing, then your body may decide it's got to put on the brakes because you don't realize that you're in pain. You don't realize you're exhausted. You're just going. Or you may be in the tired but wired state where you realize you're exhausted but you can't sleep and you're hyper and jittery at the same time that you're exhausted. Well, then your body may hit the brakes to try to slow you down. And that will cause nausea. That will cause you to lose your appetite. It causes stomach pain. It can certainly make you lightheaded by dropping your heart rate and blood pressure. Again, it makes you feel tired and ill. So now instead of just getting the occasional surge of these symptoms, now your body's got its foot on the brake almost all the time. And in fact, you pretty much have your foot on the gas and the brake at the same time. And that's a miserable feeling of being tired and exhausted and weak and dizzy, but not being able to rest. So here's a case illustration of this. ML is a lovely 33-year-old woman who now is, I think, 37. First diagnosed with chronic fatigue syndrome at age 17, later diagnosed with Ehlers-Danlos. She got about 75 to 80% better. She graduated from college. She got married. She had children. She gradually tapered off of almost all of her medicines. But a few years ago, she came in and she said, gee, for the last 3 months, my pain's been worse. My fatigue's been worse. I'm having trouble concentrating. I'm forgetting things. I can't think clearly. I'm having palpitations. My lightheadedness is back. I'm having nausea and I'm having diarrhea. So I said, well, what's set this off? Are you overtired? Are you in pain? Those would be the two most likely things. So I advised her to go back on her some pain medication for a little while to try to get more rest. But unfortunately, she didn't do those things. So not too long thereafter, she was out to dinner with friends, and she suddenly had a wave of nausea, had to run to the bathroom, diarrhea, cold sweat, and then felt like she was going to faint. And in hindsight, she realized that she had been way overdoing it that entire day. She also admitted that her pain had been pretty bad. And I said, well, we talked about your taking pain medication, did you? She said, oh, yeah, one day I took a Percocet, and I got an immediate energy boost, and I felt so much happier. The day before I saw her, she had woken up feeling tired. It was a Monday. She had woken up feeling tired, but then she felt, the day before, she said, I felt really good all day. I went to church. I did stuff with my family. Then I organized my whole closet in the afternoon when I usually have to rest. My pain was better, and I was talking really fast. I tried to go to sleep at 10, but I was still wide awake at midnight. Then I started to get stomach pain and nausea and feel dizzy and weak all over. So, why do people with Ehlers-Danlos syndrome look and feel like they have psychiatric conditions? Let's look at the diagnostic criteria for some common psychiatric disorders from the DSM-5. So the ones we'll talk about tonight are anxiety, panic, ADD, and hypomania as a feature of bipolar disorder. So anxiety, very common symptom. The criteria for what's called generalized anxiety disorder are excessive anxiety and worry occurring more often than not for at least 6 months. Of course, what's excessive and what's reasonable is a subjective decision. Patient who's anxious finds it difficult to control these symptoms, and anxiety and worry are associated with at least 3 of the following 6 symptoms more days than not over the previous 6 months. So feeling restless, feeling keyed up, feeling jittery, feeling on edge, easily tiring, trouble concentrating or your mind blanking out, being irritable, muscle tension, or trouble sleeping. You have trouble falling asleep, trouble staying asleep, or just a restless, non-restorative, unrestful sleep. And then, of course, these symptoms have to be significantly affecting daily function, either home life or social life or work life. And these symptoms have to be not due to any other medications or other medical conditions. So let's look at these symptoms again. Feeling restless, jittery, keyed up, on edge, tiring easily, trouble concentrating, being irritable, muscle tension, and having trouble sleeping. Don't those symptoms sound familiar? Sounds like if you go to the doctor, and here's a patient having an MRI, and the doctor says, the MRI reveals that your head is riddled with conventional wisdom. So this is a very good, I like this cartoon, but really, of course, it's the patient who should be telling the doctor that her head is riddled with conventional wisdom, because if you go to Dr. Conventional Wisdom with these symptoms, you may very well be diagnosed with generalized anxiety disorder. What about the criteria for a panic attack? Panic attack is defined as an abrupt surge of intense fear or discomfort, peaking within minutes, associated with 4 or more of the following symptoms: palpitations, heart pounding or racing, sweating, trembling or shaking, a sensation of shortness of breath or smothering, feeling of choking, and chest pain or discomfort. So again, if your body's making adrenaline in response to almost any kind of stress or overreacting by making too much adrenaline, you could easily have 4 of these symptoms. But there's a whole second page of symptoms: nausea or abdominal pain, dizziness or lightheadedness, fear of losing control, fear of dying, numbness or tingling, chills or flushing. All you have to have is 4 of these symptoms. And again, if you go to Dr. Conventional Wisdom, that's pretty obvious that you just had a panic attack. How about panic disorder? Well, panic disorder is characterized by recurrent, unexpected panic attacks. And you have to have worried for at least a month about having another panic attack. Well, if you're sitting quietly doing nothing and all of a sudden your heart starts pounding for no reason and people tell you you're having a panic attack, well, you're going to start wondering about why you're having panic attacks. And not surprisingly, to be diagnosed with panic disorder, you have to make changes in your behavior to avoid having panic attacks. So if you're lucky enough to figure out what certain situations, like maybe exercise or having to give a talk in public, trigger panic attacks, then you try to avoid those situations. And again, your symptoms can't be attributable to side effects of medication or another condition. But pretty simple. If you're having frequent panic attacks and your body is overreacting to stress by making too much adrenaline in response to minor stresses, sometimes stresses you can't even identify, then you describe all this to Dr. Conventional Wisdom, and you leave with a diagnosis of panic disorder. So what if you get these misleading diagnoses of panic and anxiety? The treatments you'll be offered will be medications like benzodiazepines That's Klonopin, Valium, Xanax, Ativan, and similar drugs. And these drugs will make you feel calmer. And so you'll think, well, maybe I really do have anxiety. But they can, during the day, cause fatigue and sleepiness. They're downers, so they can worsen depression, and they can impair cognitive function. So I often see patients who are taking medications like this, and I point out to them that they're complaining of fatigue and cognitive problems and depression, and they're taking medication that can cause all of those things. If you're lucky, maybe you won't get a benzodiazepine. Maybe you'll get a serotonin reuptake inhibitor. Those will also make you feel calmer because serotonin is calming, and it will, raising the level of serotonin will offset some of this extra adrenaline that your body keeps making. And it will help you worry less, but the serotonin drugs can give you a shallower, more restless, more dreamy sleep, and they also can cause nausea. And maybe you'll be referred for psychotherapy or counseling to help with your panic and anxiety, solve the problem of making a big deal out of every little thing and overreacting to minor things. And again, psychotherapy might help you cope with being sick and maybe help you react less to certain stresses. But what if your panic isn't really panic? What if your anxiety isn't really anxiety? What if these are just symptoms of autonomic dysfunction? What if your autonomic nervous system is running on empty and you're making too much adrenaline in response to minor stresses? Then the physician who's diagnosed you with panic and anxiety is not really treating the underlying problem, but only masking the symptoms, as was the case of KM that I presented to you. So a little more subtle are the diagnostic criteria for adult ADHD inattentive type. So people who are physically hyperactive are not going to be mistaken for, and will be harder to mistake for other diagnoses. But if you have primarily inattentive type, meaning you have trouble maintaining focus and concentration to a degree that negatively impacts your social life or home life or work or school, and you have to have the following features of inattentive type ADHD: trouble paying attention to details, making careless mistakes, trouble keeping attention on tasks, trouble listening when spoken to, not following through on things, trouble with organization, avoiding activities that take a lot of mental effort for a long period of time, losing things, being easily distracted, and being easily forgetful. Well, again, those symptoms sound familiar. If you go to Dr. Conventional Wisdom and list off those symptoms, the doctor is going to say, aha, I recognize those symptoms. Those are the symptoms of ADD. I can help you with that. And you might get prescribed a stimulant to help with your ADD. Less likely, you'll be prescribed some kind of counseling or psychotherapy to help with managing your daily activities. More likely, because it's much easier, you'll be prescribed a stimulant. And indeed, even though you might be treated for the wrong thing, the stimulant will help with focus and concentration and energy. But obviously, stimulants can worsen this whole sense of hyperarousal, of feeling jittery, of feeling anxious, of feeling panic. It's like taking extra adrenaline on top of the extra adrenaline you're already making. And the energy boost you get from this is very temporary, and that when the stimulant wears off, then you crash and your fatigue is even worse. And this is something that patients often refer to as the push-crash cycle, which can happen with your own autonomic nervous system going on the roller coaster, but stimulants can make it worse. And with longer-term use of stimulants, dependence and tolerance can develop, and stimulants, of course, can worsen sleep problems, they can worsen digestive problems, they can impair your appetite, they can cause palpitations. So, again, what if you have the symptoms of ADD, but you don't really have ADD? What if you have all these symptoms just because you're exhausted? As we talked about before, if you haven't slept well for a long time, you're going to be tired. You're going to be easily distracted. You're going to have trouble concentrating. You're going to be irritable. You're going to have trouble getting tasks done. You're going to procrastinate and try to avoid things that you're supposed to be doing. So again, if you're misdiagnosed with ADD, then you're really not treating the underlying problem. You may be helping the symptoms, but you're not fixing the problem. And in fact, particularly when using stimulants, there's a good chance you'll be making the underlying autonomic problems worse. So what about hypomania? Again, people who are acutely manic, that's not something that would easily be mistaken for other diagnoses. But hypomania is defined as a period of persistently elevated, expansive, or irritable mood and abnormally or persistently increased activity or energy, lasting at least 4 consecutive days and present most of the day, nearly every day for those few days. During that period, at least 3 of the following symptoms, or 4 if you're only irritable and not elevated mood, have persisted, and others will recognize this as representing a noticeable change from the usual behavior. So inflated self-esteem or grandiosity, feeling unusually great, feeling unusually powerful, I can do anything, a decreased need for sleep, so you might sleep only 3 hours and wake up feeling great and still be really productive the next day. You may be more talkative than usual. Your thoughts may be racing. You may be easily distracted, but at the same time have an increase in goal-directed activity. Like a dog with a bone, you decide, okay, I'm going to do this, and you get your mind fixed on it, and you get it done, even though you may be agitated at the same time. And you may show excessive involvement in activities that have a high potential for painful consequences. So think back to my patient ML. Her symptoms didn't last for 4 days, but she certainly had most of these features. And involvement in activities that have a high potential for painful consequences is something that most patients who are chronically ill have to live with. When they do occasionally have a good day, they tend to do too much, knowing that they will pay for it later, but doing it anyway. So while it's more uncommon for patients with autonomic problems to really meet these criteria, nevertheless, because so many of the symptoms are similar, I have seen many patients who have symptoms like this diagnosed as bipolar and treated with mood stabilizers. So again, there's a few other specific criteria for what hypomania is, but again, if you go to a physician and say, for 2 days last week, I just had tons of energy and I was running around and I got so much done and I could barely sleep. I only slept 3 hours each night, but I still felt great the next day. That doctor of conventional wisdom is going to be inclined to say that you're bipolar and put you on a mood stabilizer. But of course, once again, mood stabilizers might reduce some of your symptoms, but are not addressing the underlying problem of autonomic nervous system dysfunction. So besides the problem of not really identifying and treating the underlying problem, making the wrong diagnosis sort of obviously delays the possibility of getting a correct diagnosis. If you tell somebody they're having panic attacks, they'll believe you that they're having panic attacks, and they won't look for another explanation. You also expose patients to the risk of side effects of medications that they might not need because you're prescribing them for diagnoses that they don't have. And you raise doubts in the minds of patients that their symptoms, which they thought were physical, maybe aren't, and maybe it is all in my head after all. And unfortunately, in this day of electronic medical records, you're putting inaccurate diagnoses in the medical record. And I just saw somebody recently that went to an emergency room with, I think, with palpitations and lightheadedness, and they said, they found a record from an emergency room visit 6 or 8 years earlier, and they say, I see you have a history of anxiety. So once you get these things in your medical record, it's hard to get rid of them. So, of course, there is a possibility that you can have both. Patients who have autonomic and psychiatric conditions together can make diagnosis and treatment even more complicated. And that leads to the situation of going to the doctor. The doctor is overwhelmed by the complexity of what's wrong with you and says simply, come back when you're feeling better. So let me show you, go back to this slide to remind you of what a normal response to autonomic testing looks like and what the type of response we see to autonomic testing in patients with Ehlers-Danlos who are having autonomic problems. So I want to show you this to to make the point, this is a before and after slide, to make the point that this roller coaster represents an imbalance in autonomic nervous system function. It is not a permanent condition. So this was a patient who was totally exhausted, depressed, couldn't sleep, couldn't function, couldn't concentrate, could barely manage basic self-care, was just totally wiped out. So in her case, it took us a year and a half to get her sleep straightened out, to get her autonomic nervous system under control, to get her pain under control, to treat her depression. But over time, we were eventually able to get her autonomic nervous system response to be just about normal. And in fact, I just saw her a couple weeks ago. A lot of people do ask me, if once you have autonomic problems, are they ever fixable or do you have them forever? I just saw this patient a few weeks ago, and she's not taking any medication for any. She has no autonomic problems anymore. In fact, she's so much healthier than she was 10 years ago. It's pretty remarkable. So how do we get from this back to almost normal? Well, basically, as I said, the roller coaster represents an imbalance, and treating autonomic dysfunction is based on restoring autonomic balance. So how do we do that? Well, we go back to this cartoon. And basically, getting the autonomic nervous system to function normally again requires replenishing the energy pool, replenishing reserves. So how to do that? Very simply, we have to optimize sleep quality, do whatever we can to try and improve the quality of sleep, so we're putting more gas in the tank. And then one by one, we have to minimize all these stresses that suck up energy. So pain control. Pain control is a big one. I just saw a patient this morning who's upset that she's not getting better. And I said, well, one of the reasons you're not getting better is because you're in pain all the time. You're probably on a scale of 10, you're probably between a 4 and a 5. And she said, no, it's probably a 6. I said, okay, so all day you have pain a little 6 over 10. That's a major energy drain. And at night, that pain is disrupting your sleep, so you can't get a decent night's sleep. And she has been very reluctant to take pain medication because she's used to being in pain. And this is the response I get from lots of patients who say, oh, it's not that bad. I can put up with it. I've learned to deal with it. I really don't want to be taking lots of pain medication. But chronic pain just depletes your energy reserves and messes up your sleep. So you really need optimal pain control. Fatigue itself is a problem because every time you're exhausted and you say, oh, man, I'm really tired, but I really want to get this done today, or I'm really tired, but I have to go pick up the kids, or I have to go run this errand. Whenever you're tired and you push through it, you're essentially borrowing from the reserves to do that. So you're making the problem worse. So resting when you're tired is really a key concept in trying to restore your energy reserves and trying to normalize your autonomic function. Dehydration is a very common problem. I won't spend too much time on this, but just say that patients with orthostatic intolerance who are lightheaded and dizzy because of autonomic dysfunction associated with Ehlers-Danlos tend to be advised to eat lots of salt and drink lots of water, but in the range of 80 to 90% of them are not getting enough salt. So there is a problem where you don't crave salt when you should, but over and over again I see patients say, no, I'm eating tons of salt, but basically they're drinking so much water that the amount of salt they're eating is not adequate, and it's all about salt-fluid balance. So a lot of patients, despite how much fluid they're drinking, can be dehydrated if they're not getting enough salt. Cognitive effort is like physical activity. If you're exhausted and you have to do something cognitively demanding, that's tiring. Emotional stresses can be hard to limit, but to the extent you can, try to avoid them or let somebody else deal with them. And if you can reduce work or school stresses by having flexible deadlines or being able to work from home or things like that, that's also going to help. So again, to go over these things, that better sleep is one key to restoring autonomic balance. For most people, that means better quality sleep. For some people, that means more sleep, and that means more sleep as well. Adequate pain control, which a lot of patients and their physicians are reluctant to try to achieve because it may mean a combination of several different pain medications. Adequate salt and fluid. I didn't mention blood sugar drops, but some people's blood sugar rides the same type of roller coaster, and when their blood sugar drops, that's a major trigger for a sympathetic response. Minimize emotional stresses when you can, and again, rest when tired. Don't push through fatigue. So, in summary, autonomic nervous system dysfunction is very common in Ehlers-Danlos. It's typically characterized by a sympathetic over-response to minor stresses and then a parasympathetic overcorrection. That autonomic symptoms can be easily mistaken for symptoms of psychiatric conditions because they're the same, especially anxiety, panic, ADD, and at times even hypomania. And that treatment of these symptoms should be directed at correcting the underlying autonomic dysfunction, as well as, in most cases, reassuring patients that they do not have psychiatric conditions. So thank you all for your attention. I'm happy to try to respond to questions. I would ask you, please, to not ask for individual medical advice, since in this format I really don't have enough information about you to make specific treatment or other recommendations.
Thank you, Dr. Pocinki. We appreciate so much how understandable the content was, and wow, we really relate to it for sure in our personal experiences. We're going to go up to the Q&A box and see what kinds of questions we have so far. And you can go ahead and read those as you go through them and answer them out loud if you can.
A very long and detailed question about association of dissociative disorder, which I have to say I don't know much about, but the questioner asks about being diagnosed with dissociative disorders based largely on observed moments of absence or sort of staring spells. And that is something I've seen occasionally in some of my patients that look like so-called petit mal or absence type seizures, when patients just sort of go away, and that can be a feature of dissociative disorder. Dissociative disorder is also associated with post-traumatic stress disorder. Post-traumatic stress disorder has a lot in common with the dysautonomias as well, including the effective use of beta blockers in some patients with PTSD. The only other thing I would mention is that some patients I've seen over the years who have these sort of staring spells are literally falling asleep for 5 seconds at a time. They're so exhausted that if they stop at a traffic light, there's not enough stimulation going on to keep them awake, and they'll fall asleep. And then the car behind them blows the horn, and they wake up, and so I've seen that sort of misdiagnosis also. Okay, so there's a question about salt fluid imbalance, right, and we are fighting these societal norms, unfortunately, that salt is bad. And there's really very little data that salt is bad. For specific groups with hypertension and so on, there are some data, but general populations, it's not clear that salt is bad. Salt, unfortunately, keeps company with high-fat foods, which are bad for you. But there are certainly a lot of people who need more salt. I see patients every day who are not getting enough salt. So salt fluid balance is hard to maintain, as I said, because most patients feel thirsty all the time but don't crave salt when they should. For many people, the most The easiest solution, no pun intended, are electrolyte drinks, where instead of drinking plain water, you drink fluid that has some salt content. The simplest way, again, give you maybe a little too technical, but for people to understand this, is that your body keeps the total concentration of everything in your bloodstream in a pretty narrow range. If your blood becomes too concentrated or too dilute, then bad things like brain swelling can happen. So your body has many different systems that work together to keep this blood concentration in a pretty narrow range. So the normal range in most labs is about 280 to 300. When I looked at about 35 or 40 consecutive patients with lightheadedness who've been told eat plenty of salt and drink plenty of water, their average number, with normal being between 280 and 300, was 281. And I saw some patients who had numbers like 269 and 273. And there's no way that if the systems in your body are working properly, they should never let your blood concentration get that low. So the paradox here is that every time you drink plain water, you're diluting out your blood. And the only way the body can get your blood concentration back up is either hold on to salt or pee out the water you just drank. So this is how a lot of people complain that no matter how much they drink, they're still thirsty because they're drinking water and the water goes right through them because they don't have enough salt to hold on to it. So replacing plain water with electrolyte drinks is a useful thing. Increasing salt in your diet with some healthy snacks like olives or pickles, or drinking healthy things like tomato juice or V8 juice that have a high sodium content. Canned soups are reasonably nutritious and they're high in sodium. And the next answer people always ask, well, is it possible for me to get too much salt? And the answer is it's possible, but it's really tough because if you get too much salt and your blood gets too concentrated, your thirst mechanism kicks in. I have only, I think, twice ever seen people who managed to get too much salt. There's a question about what types of pain medications are prescribed. Frankly, that's probably another 30-minute lecture. So that's really, I think, not practical for me to discuss. Somebody wants to know why psychiatrists don't know about autonomic dysfunction. That's a good question. Most physicians in general don't know anything about autonomic dysfunction because it's not in a medical curriculum anywhere. Somebody else asked about exercise. Well, yes, exercise is very important. Building muscle tone is helpful for circulation and improves your autonomic nervous system. Exercise to build muscle tone to stabilize your loose joints is helpful to reducing pain. The problem for a lot of people is sort of redefining what's meant by exercise. So if you're somebody whose autonomic nervous system is out of whack because you're exhausted and your gas tank is depleted, then you shouldn't be doing strenuous exercise. You should be trying to conserve energy. But that doesn't mean you shouldn't be exercising. There's lots of exercise you can do that isn't strenuous. And for a lot of my severely ill patients, I have them start just flat on their back, so they're not having to even fight gravity, but lie on their back and move their arms and legs in all directions to try and build some muscle tone without aggravating pain or autonomic dysfunction. Again, so there's a question about specific pain medications, and combination of pain medications is different for different people. I mean, I guess since there's a bunch of questions about this, there are limited choices of pain medications. Basically, our options are Tylenol, aspirin and related anti-inflammatories, Tramadol, which is a slightly sort of stronger Tylenol, which has some mild narcotic properties. Then medications like Savella and Cymbalta that have some antidepressant and pain effects. Medications like Lyrica and gabapentin that have sleep and pain and sometimes some mood effects. Adjuvant medications like muscle relaxants, which can occasionally relieve pain and improve sleep. For localized pain, topical medications like topical creams or a lidocaine patch. And What else? Amitriptyline has some pain effects. And then you have narcotics. So it's a fairly limited choice, and we start with the mildest things and slowly try to use combinations of certain things for certain types of problems. But coming up with a regimen that's optimal for each person is a very individual thing. So I can't say there's any one particular type of pain medication that works best for patients. There's a question about, electrolyte drinks are expensive, and a lot of people don't like the taste. Some of them are artificially flavored. Some of them are artificially sweetened. The ones that aren't kind of taste like salt. So yes, there are, I can't give you a website off the top of my head. There are certainly recipes online for making your own electrolyte solutions or what's often called oral rehydration salts. Somebody asked a very basic question: why is Ehlers-Danlos tied to autonomic dysfunction? We don't know. There are various theories. There are theories about pressure on the spinal cord in various places. There are theories about circular impairment, the fact that your blood pressure tends to be low and circulation tends to be sluggish, and your body might compensate for that by increasing sympathetic activity, which then gets you into a vicious cycle of not sleeping well and being tired. But we do not know why Ehlers-Danlos is associated with autonomic dysfunction. The question always comes up: where do we find doctors who understand this? I wish I knew. This is why I'm doing these. This is why I do these webinars and give talks about these things. So people hopefully may have some open-minded physicians who say, "Oh, and you can take these concepts too," and they can read about them. But one-on-one, I've been able to explain these concepts to some individual psychiatrists, but in groups, psychiatrists don't seem interested in learning this. It's out of their comfort zone. It's too different a paradigm. If a beta blocker makes your depression, I guess, must be worse. If it helps with your panic, what can you do? Different people do better on different beta blockers. So the odds are that most people will find a beta blocker that can help them feel less panicky without making them feel more depressed. What type of doctor diagnoses and treats autonomic dysfunction? That's a problem. There are very few doctors who diagnose and treat autonomic dysfunction. I would say probably the majority of them are trained as neurologists. But there are some cardiologists, too, who are interested in this. The Dysautonomia International has a list of physicians on their website, dysautonomiainternational.org. Has a list state by state of physicians who have some expertise in managing autonomic dysfunction. Somebody has to have a clinical presentation to direct physicians to in order to understand how to treat autonomic dysfunction. Let's see. No, I guess the other talk on this website isn't. There are a number of talks I've given in the past on evaluation and management of autonomic dysfunction. Hopefully your search engine can find them. Okay. How to manage high blood pressure with autonomic dysfunction. Most of the time, high blood pressure with autonomic dysfunction is the manifestation of making adrenaline in response to pain and fatigue. So the treatment is usually beta blockers to reduce the blood pressure and block some of the extra adrenaline, but then trying to identify the underlying causes that the body is making adrenaline response to. Okay, if someone has autonomic dysfunction, can it trigger or lead to other conditions such as gastroparesis or mast cell reactions? Well, so certainly it can, whether it leads to or not, but certainly, as I mentioned, when your sympathetic nervous system activity is high, your parasympathetic nervous system activity is low. So if you're making adrenaline response to fatigue and pain and you're feeling jittery and anxious all the time, then your digestive system, which is probably sluggish to begin with, is going to be even slower. How this ties in with mast cell reactions is not clear, except that in a sort of analogous way, your mast cell seems more likely to overreact when you're overtired, dehydrated, stressed out, run down, or in some other ways your system is out of balance. Okay, conversely, can mast cell disease cause autonomic dysfunction? Well, it's not clear. It can certainly aggravate autonomic dysfunction in many different ways, but one of the most sort of clear-cut is that one of the major things of a couple hundred things that mast cells can make is histamine, and one of the major physiologic effects of histamine is to make blood vessels leaky. Fluid leaks out of the bloodstream into the tissues. So when you have a localized allergic reaction, it swells, even just a mosquito bite or something like that. And when your circulation is not very good in the first place, then having fluid leak out of your bloodstream into the tissues causes a drop in circulation, and your body responds to that by making adrenaline to try to compensate. So mast cell disorder certainly can aggravate autonomic dysfunction. Okay. Yeah, someone asks for, right, there's a paper I wrote on the general hypermobility syndromes and various aspects of hypermobility. That maybe, I think I might have given that to John and Deanna to post along with this talk. If not, I can send it to them, but I think I did. What blood test has sodium concentration? A normal electrolyte panel will measure your sodium concentration, though frankly the more helpful thing to look and see whether you're getting enough salt is to look at how much salt is in your urine. If the concentration of sodium in your urine is very low, then you know you're not getting enough salt. You know your kidneys are trying to hold on to as much as they possibly can. And usually at the same time, your urine will be very dilute, because again, your body is trying to raise that blood concentration number by dumping out extra water and by holding on to as much sodium as they can. So some experts recommend collecting urine for 24 hours, but I always accuse them of never having tried to do that themselves. I find it pretty helpful just to check out urine sodium level on patients who say, gee, no matter how much no matter how much water I drink, I'm still thirsty or I'm still lightheaded. Okay, then there's a question on vestibular symptoms. Vestibular system is located partly in the inner ear and then regulated by the vestibular cortex in the brain. So there are a number of vestibular problems that we see in patients with Ehlers-Danlos and with autonomic symptoms. The most analogous to what we've been talking about tonight is to think about the roller coaster, the ups and the downs, and to picture that if you move your head just a little bit to one side and your body overreacts to that signal, then it sends a message to your brain saying you've moved further than you actually did. So then you turn your head back further than you need to straighten it back out again, and then you overreact to that movement and turn your head back too far the other way, trying to straighten it out, and pretty quickly you're holding on to something to make your head stop spinning back and forth. The other thing I've seen off and on over the years and several times in the past couple of weeks gets into trigger points and referred pain syndromes, and there are specific muscles in the neck that actually what we call refer to the inner ear. And there are patients who can have vestibular problems, who can have tinnitus, who can have ear pain, who can have decreased hearing, have a number of ear symptoms that actually are referred from muscle spasms in the neck. So that's a couple illustrations of vestibular problems that can be associated with autonomic issues and with Ehlers-Danlos. Are beta blockers contraindicated in patients with mast cell activation? It depends on whom you ask. Most allergists will tell you that, if you have asthma, you shouldn't take beta blockers. If you have severe allergic reactions, if you've ever had anaphylaxis, then you shouldn't take a beta blocker because you could, if you ever had a severe anaphylactic reaction and need to be given epinephrine, you might not react to it if you have a beta blocker. Unfortunately, that is contrary to exactly what's wrong with your autonomic nervous system. And in fact, if you ever had to get epinephrine, your blood pressure and heart rate might go through the roof, and it might be a very helpful thing for you to be on a beta blocker. But that belief is not supported by the literature, shall we say. So I have many patients with mast cell disorders who take beta blockers and do fine with them. Would a beta blocker be contraindicated if your heart rate is 55 during sleep? Again, it depends why your heart rate is 55 during sleep. If you're really in good shape, or your autonomic nervous system is functioning properly at night, and your sympathetic activity is low and your parasympathetic activity is high, then you don't want to take a beta blocker overnight. If your heart rate is slowed during the night because you're making adrenaline and your body is making you nauseous, trying to get you to slow down and sleep, and the nausea is keeping your heart rate down, then you should be on a beta blocker to sleep better and not be nauseous. Okay, I think we're coming to the end. Okay, a few examples of beta blockers. Beta blockers, common beta blockers. There are many different beta blockers. Why some people do better on some than others. Propranolol was the original beta blocker. It's a very short-acting drug. A lot of people take this for performance anxiety. It kicks in quickly. It lasts 4 to 6 hours. Similarly, some patients take it at bedtime because it doesn't last very long. There are long-acting versions of propranolol. Propranolol has the benefit and drawback that it crosses into the brain. So it can occasionally cause depression, cause fatigue, cause nightmares. But by the same token, a lot of the autonomic dysfunction is in the brain. So for most people, that's an advantage. Metoprolol is another beta blocker that comes in both short-acting and long-acting forms. Does not usually get into the brain. Is less likely to aggravate asthma. Then there are some beta blockers that last for 12 hours. There are some beta blockers that last for 24 hours. And then there are important differences in the beta blockers in how they're metabolized in terms of the pharmacogenetics that hopefully you'll hear about in a couple weeks. A lot of beta blockers are metabolized through what's called the 2D6 pathway, but as about 40% of the general population aren't normal 2D6 metabolizers, so they're better off not using those beta blockers. So there's a lot of variability. There's a lot of different choices in beta blockers. I think I'm running out of steam here. I'll try to answer a couple more questions. My heart rate was 130 in my sleep. The doctor said because I was dreaming. Does that make sense? Well, I'll bet that was a very vivid dream, and that when you woke up, you could remember all the details of your dream, because that vividness and that ability to remember the details is a direct result of how much adrenaline you were making at the time. So if you were having a scary dream and your heart rate was really fast, that's probably an example of overreacting to a minor stress. This has important implications for PTSD and troops coming back from the war with flashbacks and nightmares and things like that. and how high adrenaline is related to that. Beta blockers doesn't get in the brain. Actually, most beta blockers don't get into the brain. Propranolol does. Most other beta blockers generally don't. Of course, the Ehlers-Danlos patients don't always follow the rules, and in some patients we see medications that aren't supposed to get into the brain clearly are. Okay, and maybe the last question here. Is hydrochlorothiazide an acceptable medicine for blood pressure without stimulants? Hydrochlorothiazide is a diuretic. So in general, I would not recommend taking diuretics for people with Ehlers-Danlos who have high blood pressure. In most cases, Ehlers-Danlos patients with high blood pressure, again, have high blood pressure because they're making too much adrenaline in response to fatigue and pain. And dehydration in Ehlers-Danlos patients in the setting of dysautonomia, dehydration is just going to cause you to make more adrenaline. So I've seen patients with fairly bad hypertension who, once we took them off their diuretics and increased their salt intake, their blood pressures came down. So again, this is counterintuitive. Most physicians think, we're taught that first-line treatment for high blood pressure are diuretics. But if your blood pressure is high and you have autonomic problems, taking a diuretic will just cause you to be dehydrated, and that will further increase sympathetic activity and make your blood pressure worse. So in general, I would not recommend that. Okay, I think that's, I'm going to call it a night, if that's okay with everyone.
Okay, great. You got to the majority of the questions. Thank you so much for taking time to go through all of those. Wow, I don't know how else to thank you. We just really appreciate you.
Thank you all for your time and attention, and for and obviously for posting this online for the people who couldn't be with us tonight.
Oh, it's our pleasure. We just really appreciate that. I mean, years and years of dedication you've had to our patients. I mean, you're one of those handful of doctors that just has really stuck with it and really been there for us. And,
well, thanks. You know the demand far exceeds the supply, so having folks like you being able to disseminate these concepts far and wide is a helpful way to at least get these concepts out there, get patients have a better idea of what's going on, and maybe even get their doctors to help understand stuff.
Right.
Thanks.
Yeah. Thanks a lot. We're gonna go ahead and close up the session for tonight, and we appreciate Dr. Pocinki sharing all of his knowledge and years of patient experience with the EDSers. We're going to mention again that our next webinar is on September 6th, and do join us for that. We're going to talk about the U-script gene testing, so you can find out about not only drug interactions, but drug and genome interactions. And Genelux offers special screening so that you can find out if there's certain drugs you should be avoiding or you should be dosing differently due to your genetics. And I'm going to go ahead and turn it over to John to close up the meeting.
Well, I agree with you, Dr. Pocinki. It's really great that this is actually the second webinar you've done for us, and it's a wealth of information. It's one that many of our members have been struggling with because, like you were saying, most of the doctors just don't understand it. So you have understanding, you have a way to communicate it to us so we understand it better and we can relate to it and help ourselves and be advocates for ourselves, which is extremely important.
Great.
So again, we appreciate that. And I'd just like to remind people that these programs are free. We post them. They're on recordings. We have over 60 on our site right now, and you're welcome to go to our webinar page and be able to sort by presenter's names, location, or specialty. So that's something we just set up, and we're really excited about that. So, and the programs are sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. So please go out and see the products that we offer, and that helps fund this program. So again, we'll close out for this evening, and those that have joined us, we really appreciate your attendance and your continuing support for our programs. And again, thank you, Dr. Pocinki and Deanna, and we're going to call the evening. Thank you.
Hey, thank you, John.
Good night.
Good night.
Thanks, everyone. Good night.